Hello and welcome. My name is Ashton Birdie, and I will be doing my presentation today on the musculoskeletal topic for the SOAP Note Week 2. And today is 7/7/26, and this is for FMP 597. All right, so the patient we saw, or I saw with my preceptor last week, was on July 1st, and this is a male, white male, and all names and date of births are protected for HIPAA purposes. Patient's initials are DG. He is 69 and again, white male. He comes in with a chief complaint. My right knee continues to bother me on and off. It's been bothering me for months now. So this is a 69-year-old security guard gentleman. He's a reliable historian, comes to the clinic for acute on chronic issue regarding his left knee. He reports the discomfort started about a week ago when he started walking up a hill. It really aggravated him, and that's kind of what prompted him to come in. But this has been an ongoing issue for about 10 months now, on and off with some discomfort. So does not recall any injury or trauma 10 months ago or any sort of twisting or feeling of catching or locking. That is not occurring at this visit or in the last couple of weeks, nor did it happen at the 10-month marker or 10 months ago when it started. He does, however, explain the pain as achy and reports occasional popping noise in his knee and some sort of what he describes as sensation of maybe giving out. Not all the time, though. He does note some mild swelling to the inner aspect of his left knee. Otherwise, he reports the pain 2 out of 10 and does take some ibuprofen, but not consistently. So with that being said, he has denied the use of ice or heat over the affected area, and the pain has gotten better even without with minimal treatment. So the pain has not gone away fully, and it keeps coming back. So he's now in the clinic trying to figure out perhaps the root cause of this. His medical history is some gout, hypothyroidism, GERD, BMI of 32, and a total knee arthroplasty approximately 7 to 8 years ago. He is compliant with medications, so he states no allergies to medications. And for purposes of very short time to get through all of this, we're just going to hone in on what's important. Diet recall. So in that area of medical information, we need to ensure we do a diet recall with the history of gout. So real quick, we're just a couple things I'm brewing as I'm thinking about all my options and differentials. He's 69-year-old male. A big joint is involved. He is overweight. He hears some popping noises in his knee and occasional feeling of giving out. These could be mechanical symptoms, and we'll get to that in a little bit, but my brain is kind of thinking gout, possible OA, and meniscal tear. So going forward, diet recall to kind of looking for a high appearing diet with history of gout. So breakfast, lunch, and dinner, he likes his soda, he likes his beer, he likes processed foods. So we want to keep mind of that. He is a security guard. He doesn't do a ton of exercising and no routine regular exercise outside of work. He does a lot of driving in his vehicle, a little bit of walking, but that's about it. He does have tobacco, half a can per day. He has roughly 2 to 3 beers a day, and caffeine 1 to 3 cups, but denies illicit drug use. He is overweight, 247 pounds, 6'1", and BMI of 32. Elevated blood pressure a little bit. Otherwise, he denies fever and chills, no recent infection, no unintentional weight loss, no complaints of any sort of cardiovascular or pulmonary issues. And he states that in addition to what he was already reported in his HPI, he can bear weight without issue, and it's not impeding in his gait or mobility. So going into our physical assessment, he's alert and oriented, does not appear distressed, and is well groomed. He did show up in his uniform, as a matter of fact. Respiratory, great. Everything was benign within normal range. Lungs bilaterally are clear, and a regular rate and rhythm for cardiovascular. So he did deny certain things that may not allude to OA, and there was no Herbin's or Bouchard nodes that were noted. Not to say he doesn't have OA, but there's just some classic signs, right? There was visible swelling at the left medial knee without erythema or increased warmth. A little bit of crepitus noted with flexion not, with the flexion and extension, and a little bit of range of motion with the flexion. Otherwise, he has strength bilaterally, 5 out of 5 in the lower extremities, no appreciable effusions. DTRs are +2. Sensation is intact bilaterally, sharp and soft. We did do the McMurray's test. We did hear soft audible clicking. However, this could be related to degeneration if there is any OA, which can lead to stiffness, bony enlargement, and then mechanical symptoms as we were hearing, popping or the giving away sound. Anterior and posterior were negative. Lackman was negative. We did do some CMP, CBC, CRP, uric acid, and even, if needed, the anti-CCP if the CRP was elevated. Ordered a X-ray of him weight bearing with a PA view to ensure we get the view of the weight bearing enhances the joint space narrowing to really get a good view if that is true OA. So some differentials is the OA or osteoarthritis, calcium pyrophosphate disposition disease. And we have medial collateral sprain, degenerative meniscal tear, and gout. I chose OA with maybe even signs of meniscal tear due to the degeneration. That's a possibility. And it could be a low-grade gout. So we'll find out based off labs. So plan is get the x-rays as we did, waiting for those impending. Determine the need for pharmacological therapy, patient education, discuss weight loss, and consider referral to ortho if symptoms don't improve after doing all these remedies, and discussing non-pharmacological treatment. All right, so we're going to follow up the CBC, identifying for any anemia, infection, inflammatory processes, baseline renal function in case we need to do NSAIDs, and then a CRP, which would be normal in OA, but if there's any sort of inflammatory marker, such as an autoimmune disease, RA, or lupus. NSAID or topical is our first treatment. If that fails, then we would go to oral. Again, we want to be mindful if we're doing oral NSAIDs that can retain sodium. This can be bad in known heart disease. Lowest dose for the shortest period of time. Exercise for non-pharmacological treatments, trying to hurry. Weight bearing is the best. Weight loss is also a great option, at least 5%. He'll see a significant improvement in symptoms. 5% for him would be roughly 13 pounds. In addition to acupuncture, physical therapy to improve range of motion, and then even taking classes to be more autonomy or more self-sufficient with his own disease processing. Understanding his ability to know medication expectations and adherence, and then follow up in roughly 4 to 12 weeks after initiating non-pharmacological and pharmacological treatment, along with assessing symptoms. And then once stable, we will see him annually unless other concerns arise.